So, a very good afternoon to you all. Hope you are all doing well. Today, I am going to talk about the regressive alterations of tooth, which include your resorption of tooth, hypercementosis of tooth, and cementicles. Now, to start off with resorption of tooth. Now, shading of a deciduous tooth is a physiological process. And this physiological process of shading of deciduous tooth is gradually accomplished by gradual resorption of the roots of the deciduous tooth by means of cells called odontoclasts. So, resorption of the roots of the deciduous tooth are being performed by a group of cells called odontoclasts. What are odontoclasts? These are osteoclast-like multinucleated large cells with vacuolated cytoplasm and peripheral brush borders containing abundant mitochondria and a large amount of acid phosphatase which helps in the resorptive activity. Now, it is observed that once the deciduous tooth is exfoliated or shed, in its place there is eruption of the succedaneous permanent tooth. How does this eruption take place? To put it simply, the succedaneous permanent tooth gradually begins to put pressure on the deciduous tooth, through which gradual resorption of the roots via odontoclasts take place and also some pressure on the bone take place. So through resorption and repair on the bone and surrounding tissues, the deciduous counterpart is shed and in its place there is eruption of the succedaneous permanent tooth. Now all this I have talked about is related to physiological resorption of tooth. Sometimes it is observed that minute microscopic resorptions pertaining to the root surfaces of permanent teeth can also take place. These are very minute and very fine whatsoever and cannot be detected by routine radiographic procedures. It is the pathological resorptions which is of much significance because they are the ones which can be detected or visualized by radiographical methods. I repeat, pathological resorptions are the ones which can be detected by visualized by radiographical methods, and pathological resorptions of significance can be of two types, that is your internal resorption of tooth and next is your external resorption of tooth. We will begin with the internal resorption of tooth. Now, internal resorption is a relatively rare type of resorption of tooth. In the beginning of the internal resorption procedure, the tooth is relatively asymptomatic, but as the process continues and there is pulpal inflammation involved, pain will certainly be there. So, in the initial phases, although it is asymptomatic, as pulp tissue gets involved and inflammatory process sets in, there will be an advancement of pain. What is the definition of internal resorption of tooth? It is a type of pathological resorption which begins from the pulpal surfaces and associated with the cells of the pulp. So, it is a type of pathological resorption of tooth which begins from the pulpal surfaces and is associated with the cells of the pulp. The internal resorption of the tooth can be of two types. It is classified in two types. First is your inflammatory type of internal resorption. Next is your metaplastic or replacement type of internal resorption. So it is of two types, inflammatory and replacement type of internal resorption of tooth. Inflammatory type of internal resorption of tooth is characterized by gradual resorption of the dentin, which is located very close to the pulp chamber by cells called odontoclasts, and the resorbed dentin is gradually repaired, or this area is gradually occupied by means of a large vascularized, edematous, inflamed, and necrotic pulpal tissue. I repeat, the dentinal wall in close proximity to the pulp and pulp chamber is resolved by odontoclast, and this area is occupied in inflammatory resorption by means of a enlarged vascular, hyperemic, edematous, and lastly a necrotic pulpal tissue. These usually tend to occupy the cervical region of the tooth, and the resorption usually continues until and unless the vital pulp is there. The resorption procedure will go on to continue until the vital pulp of the tooth is there. Initially, it is asymptomatic, but as pulpal inflammation sets in and inflammatory mediators like cytokines and chemokines are there will certainly be an advent of pain in this regard. Now, which regions of the pulp chamber or the pulp canal are the ones which are commonly affected by this inflammatory type of internal resorption of tooth? These are actually the coronal portion of the pulp chamber or pulp canal. It becomes necrotic and the apical portion is spared. So, in the coronal portion pertaining to the pulp chamber or pulp canal, the inflammatory type of internal resorption usually sets in, while the apical portion is usually spared. Now, it is observed that if this inflammatory, vascular, hyperemic, edematous, and ultimately necrotic changes go out of bound or they become excessive in nature, it encompasses a large area of the coronal portion pertaining to the pulp chamber or pulp canal. It might so happen that the crown portion of the tooth might show a pinkish discoloration, which is known as the pink tooth of Mummery. The spelling is Mummery. So, what is pink tooth of Mummery? If the vascularity, inflammatory nature, edematous nature, the enlargement of the pulp, the hyperemia, and ultimately necrotic procedure of the pulp becomes excessively large so that it is out of bound and involves a large portion of the coronal aspect of the pulp chamber, so that the crown of the affected tooth shows a pinkish discoloration that is exhibited clinically by the term pink tooth of Mummery. Now, when it usually involves the coronal aspect of the pulp chamber, a characteristic radiological appearance is usually observed, that is, a well-defined, uniform, symmetric enlargement of the pulp chamber or pulp canal. When the inflammatory resorption involves the coronal part of the pulp chamber, a particularly well-defined, uniform, symmetric enlargement of the pulp chamber of the coronal part of the pulp is usually observed. However, when this vascularity, hyperemia, edematous or necrotic changes become rather even more excessive, it will not only encompass the coronal third of the pulp chamber, but rather will gradually go on to progress to involve the middle and apical third of the pulp chamber too. And when it involves the apical third of the pulp chamber aspect, the inflammatory resorption radiologically is visualized as a ballooning enlargement of the pulp chamber. An inflammatory resorption, the inflammatory pattern of internal resorption in the apical third of the pulp canal is radiologically exhibited as a ballooning enlargement of the pulp chamber. And when this involvement of the pulp chamber by the edematous, vascular, hyperemic, and necrotic pulp involving all the domains, that is the coronal, middle, and apical aspects, becomes increasingly excessive, it might so happen that from inside out, that in the first there is resorption of the dentinal walls just close to the pulpodentinal complex, and the defect goes on to destroy the tooth from inside to outwards. There will be gradual destruction of the external and lateral surfaces pertaining to the root. So the lateral surfaces on the root will also be perforated, and this will somewhat mimic that of the external resorption procedure, although it is never an external resorption because it is occurring from inside out. That is, from the inside dentinal walls are destroyed first, and then the process goes on outwards. It is initiated by the pulp cells, and it is a type of pathological resorption of tooth which begins from the pulpal surfaces and is associated with the cells of the pulp tissue as well. Now we will go on to shift our focus on the replacement or metaplastic type of tooth resorption. In replacement or metaplastic type of tooth resorption, the resorption of the dentinal walls in close proximity to the pulpodentinal complex is being achieved by the odontoplast, and that resorbed area is replaced or repaired by woven bone or cementum, or a combination of two, that is the bone and the cementum, which is known as osteocementum in common parlance. So to repeat it again, in metaplastic or replacement type of internal resorption, it is observed that the dentinal wall in close proximity to the pulpodentinal complex is resorbed by cells called odontoclast, and this resorbed dentin is being repaired and replaced by means of woven bone, cementum, or a combination of bone and cementum together, which is known as osteocementum. And radiologically, how is the appearance of this metaplastic type of internal resorption? It appears that the material or substance present within the pulp chamber or pulp canal, it has a lower radiodensity than that of the surrounding dentin. So radiologically it will appear that the material present inside the pulp chamber or pulp canal, it will seem to possess a lower level of radiodensity than that of the surrounding dentin. Now we will shift our focus to external resorption. At first, the definition of external resorption of tooth. What is external resorption of tooth? External resorption is the type of pathological resorption of tooth which starts from the root surfaces and is associated with the cells of the periodontal ligament. I repeat, external resorption is the type of pathological resorption of the tooth which is starting from the root surfaces and is associated with the cells of the periodontal ligament. It radiologically is exhibited as a ill-defined moth-eaten radiolucency, which usually involves the middle and apical third of the root, and the coronal part of the pulp chamber is usually spared. So it is exhibited as an ill-defined or moth-eaten radiolucency, which usually tends to involve the middle and apical third of the pulp chamber, and the coronal third is usually unaffected or it is spared. Clinically, it is observed that the crown of the tooth is afflicted to a great extent even before the tooth erupts in the oral cavity. So when the tooth erupts in the oral cavity, it might seem as well that the tooth has undergone premature caries, but no, actually it has undergone external resorption of the tooth. Now there are certain factors which are associated with the external resorption of the tooth, and I'll tell them and I'll also repeat them. These are cyst, tumors, occlusal stress, trauma, pressure, especially mechanical pressure related to the orthodontic treatment, wherein balance or homeostasis between bone resorption or repair is not properly maintained. Next is your hormonal imbalance or intracoronal bleaching of a pulpless tooth, periradicular inflammation, periodontal treatment such as splinting of tooth, herpes zoster virus infections, and trying to reimplant an avulsed tooth. I repeat again. The causes associated with external resorption of tooth include cysts, tumors, stress like occlusal stress, trauma, pressure, especially mechanical pressure from orthodontic treatment, wherein a balance between bone resorption and repair are not maintained, hormonal imbalances, intracoronal bleaching of pulpless tooth, periradicular inflammation, periodontal treatment such as splinting of tooth, herpes zoster virus infections, and trying to reimplant an avulse tooth, all this can lead to your external resorption of tooth. Now, coming to the main point of concern. Now, if we try to reimplant an avulse tooth, what can happen? Now, due to avulsion of tooth, it is extruded from the oral cavity or the mouth and it is exposed to the external environment. Now, if it is exposed to the external environment for a prolonged period of time, what happens is basically the cells which are on the periodontal ligament surface, they actually undergo die out. They actually undergo apoptosis. They shrink out and they undergo apoptosis. And even if after the apoptosis, if we try to put the tooth back or reimplant it in its original position, also to put it simply, if we try to put it back into the socket, our human immune system will perceive that tooth as foreign as the attachment apparatus cells have undergone apoptosis and will immediately begin or start out a foreign body reaction against the cell, and an external resorption will ensue in this matter. So, this is to be taken into consideration. Another point of contention, as I have mentioned earlier, is your orthodontic treatment. If the balance between bone resorption and bone repair is not properly maintained, it might lead to excessive external resorption of a particular tooth. In this method, maxillary anteriors, particularly the maxillary incisors, are commonly affected. So, sometimes it can also be observed that the external resorption of tooth, although it usually affects the middle and apical aspects of the pulp chamber or the pulp canal, it can sometimes also start or begin from the cervical third of the pulp chamber or pulp canal. It can start its course through a very small opening, and later, rather on, it will go on to encompass a large portion in the middle and apical third of the tooth root in the pulp chamber area, that is an large area of the cementum in between the dentine and pulp tissue will be encompassed. So it can also start its course from the cervical third of the pulp chamber or pulp canal through a very small opening, and later on go on to accumulate its course in the middle or apical third of the pulp chamber, thereby encompassing a large area of cementum in between the pulp and the dentine. This is known as your cervical invasive resorption. This is known as your cervical invasive resorption. Now, there is also another type of external resorption of tooth. We have already discussed the cervical invasive resorption. Apart from cervical invasive resorption, the other type is multiple idiopathic root resorption. This is usually associated with bacterial, traumatic, or inflammatory changes. As a result of this bacterial, traumatic, inflammatory changes, like I have mentioned you before, like cyst, tumors, stress, trauma, periradicular inflammation, herpes zoster virus infection, inadvertent trying to bleach the intracoronal bleaching of a rootless tooth, if we try to do this, there will be an ensuing inflammatory process or unwanted complications which will lead to excessive accumulation of chemical mediators of inflammation, such as like interleukin, cytokines, prostaglandin, etc., which will lead to activation of the clastic cells of the periodontal ligament, and thereby resorption of the root in the apical third area, because the area is most susceptible for external resorption of tooth. So, what is multiple idiopathic root resorption? It is a type of external resorption of tooth in which the causative factor is usually bacterial, traumatic, or inflammatory stimuli, which will lead to accumulation and activation of chemical mediators of inflammation. And these include your chemokines, cytokines like interleukin, prostaglandins, etc., which will activate the clastic cells of the periodontal ligament, thereby leading to its resorption. And the resorption will chiefly involve the apical third pertaining to the pulp chamber or the pulp canal area. Another type of external resorption of tooth is your progressive external resorption. Progressive external resorption of tooth is associated with hormonal imbalances like parathyroid hormone imbalance, such as hyperparathyroidism, or systemic disturbances like Paget's disease. So, progressive external resorption can be associated with hormonal disturbances like hyperparathyroidism or systemic disabilities like Paget's disease of bone. Radiologically, how will you differentiate between internal and external resorption of tooth? Internal resorption of tooth radiologically will always tend to involve or be superimposed directly on the pulp chamber or pulp canal area, especially pertaining to the coronal aspect of the pulp chamber. Whereas the external type of resorption of tooth, the radiological defects such as moth-eaten radiolucency, etc., it will be always away from the pulp chamber or pulp canal area. So the radiolucent defect or the radiological defect will tend to shift away from the pulp chamber or pulp canal area rather than being superimposed on it, as like internal resorption of tooth. Internal resorption is actually quite rare, and external resorption of tooth is actually very much common. Internal resorption usually tends to involve the coronal aspect of pulp chamber or pulp canal, while external resorption usually tends to involve the middle and apical third of the pulp chamber. Internal resorption is usually occurs up to the point up to which the vital pulp is present, whilst external resorption can be regulated by a myriad of factors like cyst, tumors, stress, trauma, external factors like herpes zoster virus infection, periradicular infection, periodontal treatment like splinting, etc., or trying to reimplant an avulse tooth, etc. So these are the basic categories of differences between external and internal resorption of tooth. Now, coming to the histological aspects of resorption of tooth. At first, we are going to deal with the inflammatory type of internal resorption of the tooth. In inflammatory type of internal resorption of the tooth, at first, the resorption of the dentinal walls is being performed by cells called odontoclasts. The resorption of the dentinal walls in close proximity to the pulp is being performed by cells called odontoclasts. These are large multinucleated cells with cytoplasmic vacuolation and peripheral brush borders, having a large amount of mitochondria and increased acid phosphatase activity for the purpose of resorption. So odontoclasts are large multinucleated cells having cytoplasmic vacuolation and peripheral brush borders. Along with that, there is increased amount of mitochondria and large acid phosphatase activity for the purpose of resorption of the tooth contents. Now, after the resorption of the tooth, the area is occupied by vascular, hyperemic, enlarged, inflamed, and ultimately edematous and necrotic pulp. So there is increased degree of collagenization and inflammatory cells. There is increased degree of collagenization and inflammatory cells. What are those inflammatory cells? These are mainly your lymphocytes, histiocytes, and polymorphonuclear neutrophils. The inflammatory cells usually are lymphocytes, histiocytes, and polymorphonuclear neutrophils. Now, we will shift our focus towards the histopathological aspects of replacement type of resorption of tooth. In replacement type of resorption of tooth, that is the replacement type of internal resorption, we see that the resorption of the dentinal walls in close proximity to the pulpodentinal complex is being performed by the odontoclasts. Now, these odontoclasts have features similarly as I have told you earlier. In addition to that, the resorptive defect in the dentinal wall is being repaired by a complex of woven bone individually, cementum individually, or a combination of bone or cementum combined together known as osteocementum. So, the resorptive process of dentinal walls is performed by odontoclasts, and the repair of this resorbed dentinal walls of the pulpodentinal complex is being performed by either individually by woven bone or by cementum or a combination of woven bone and cementum, which is sometimes known as osteocementum. So these you have to keep in mind. Now, what is the histological picture of external resorption of tooth? In external resorption of tooth, the resorptive defect is repaired by means of osteodentin. In external resorption of tooth, the resorptive defect is repaired by means of a compound called osteodentin. And if there is excessive amount of resorption, it will be counteracted by a large amount of repair as well. If there is excessive amount of resorption in external resorption of tooth, it will be counteracted by a large amount of repair as well, and as a result of which sometimes there will be ankylosis of tooth. So, formation of osteodentin to repair the resorptive areas of dentinal resorption and formation of ankylosis in areas of repair so as to counteract for the excessive bony resorption are two characteristic pragmatic features of external resorption of tooth. Now we will shift our focus towards the treatment modality and modus operandi of management of internal and external resorption of tooth. In case of inflammatory and replacement type of both internal resorption of tooth, first what we have to deal with, there is enlarged, vascular, inflammatory, edematous and necrotic pulp. We have to endodontically completely debride this necrotic component. This edematous, vascular, inflamed and necrotic component, we have to endodontically completely take out or debride and clean out the pulp chamber or pulp canal and disinfect it as much as possible. If the defect is initially just starting to show in the initial phases, just involving the coronal part of the pulp chamber, then by doing this and completely and thoroughly debriding it endodontically, the tooth might as well as be salvaged. However, if the defect is relatively extensive and it causes extension towards the external surfaces of the tooth, as in case of pink tooth of mammary, wherein it extends towards the external lateral surfaces of the tooth and causes perforation in these surfaces. To repair or make up for the perforation, we need to apply calcium hydroxide pastes. If there is perforation in the external lateral surfaces of the root, we need to apply calcium hydroxide paste. This calcium hydroxide will help in the regeneration of dentin, but it has to be kept in mind that at least a period of 6 weeks is to be given for the dentin to regenerate. If the process is, we can control the process by this time frame, the tooth can be saved. However, if it is still extensive and along with perforations, the vascular, inflamed, edematous and necrotic pulp is grotesque in nature and it is extending to the very extremes of other parts of pulp chamber, including but not limited to middle and apical parts of the pulp chamber and pulp canal, and there is extensive destruction inside out, leading to multiple perforation or fenestration on the external part of the root surface, then we have no other option left out but just to extract the tooth. Otherwise there will be spread of infection to other parts of the body and especially the regionally important anatomic structures. Now, with treatment modalities for the internal resorption of tooth completed, we'll shift our focus for the management of external resorption of tooth. How to manage the external resorption of tooth? It usually occurs that in the apical or middle third of the pulp chamber or pulp canal. So surgically it should be visualized or exposed, that is the apical third of the pulp chamber or pulp canal, and the pulp should ideally be surgically or endodontically or by a combination of two should be surgically debrided thoroughly so that any semblance of pulp tissue is not there. Sometimes a treatment called episectomy can be done. By means of this, the tooth can be saved. However, it is observed that if there are underlying pathologies like cysts, enucleation or curettage has to be done. If there is a tumor, then surgical removal has to be done. If there is stress, occlusal stress, it has to be orthodontically corrected. If there is trauma, it is to be removed. Mechanical pressure has to be handled optimally, that is, there should be a proper balance between bone resorption and repair by orthodontic means of the treatment. If there is varicella zoster or herpes zoster virus infection, it needs to be corrected. If there is periradicular inflammation, it should ideally be contained. And if there is periodontal ligament problems, then treatments like splinting should not be done. And there might also be faulty intracoronal bleaching of tooth, that should also not be done. And if there are hormonal imbalances like parathyroid hormone etc., that should be properly corrected. Now, if there is a localized or diffuse inflammatory process, it is best controlled by a combination of antibiotics, namely amoxicillin and metronidazole. This is the best antibiotic choice so as to prevent the spread of infection from being localized to generalized, that is, preventing the spread of anachoretic or blood-borne infections at its root. Last but not the least, avulse teeth management also plays a pivotal role. If avulse teeth is not properly handled or controlled and it is abruptly reimplanted in the oral cavity, it will also lead to external resorption of tooth. So how to control it? Suppose a tooth is avulsed and come out of the oral cavity, that tooth has to be properly contained in a preserving media such as HBSS or Hank's balanced salt solution, milk or saliva. That is, the tooth must ideally be contained, the avulsed tooth, in a preserving media like Hank's balanced salt solution, saliva, etc. and should ideally be replanted within 18 hours itself, post which apoptotic changes within the cells of the periodontal ligament might begin to take place and the body will perceive the reimplanted tooth as immune and begin external resorption. So, with internal and external resorption being out of the way, we will shift now our focus to hypercementosis or cemental hyperplasia. What is hypercementosis? It is a non-neoplastic condition characterized by deposition of an excessive amount of secondary or cellular cementum pertaining to the entire root surfaces. However, it is especially localized to the apical third of the root. This excessive deposition of secondary or cellular cementum on the root surface usually occurs in addition to the normal quota or normal conglomerate of radicular cementum formation. So I repeat the definition. What is hypercementosis of tooth? It is a non-neoplastic condition which is being characterized by the deposition of an excessive amount of cellular or secondary cementum on the root surfaces throughout, especially pertaining to the apical third of the tooth root. This is in addition to the normal complement or quota of the radicular cementum which is being formed. So the type of cementum is secondary or cellular cementum which is distributed throughout the entire root surfaces. Now, what are the etiological factors which can predispose to the formation of hypercementosis of tooth? These are of 5 types. First is your accelerated elongation of a tooth. Second is your inflammation of a tooth. Third is your repair of a tooth. Fourth is your systemic disturbances like Paget's disease. And fifth is your idiopathic causes. To begin with, we'll start with the accelerated elongation of a tooth. Now, what happens when a tooth has no antagonistic tooth in the opposing arch? Suppose there is a maxillary first molar and the antagonizing mandibular first molar has been extracted owing to caries. So that maxillary tooth has no antagonizing tooth. It will continue to erupt however small it might be through the process of passive eruption. It has to be contracted. It has to be counterbalanced. This contraction can be done by the process of hypercementosis. This contraction can be done through the process of hypercementosis by achieving the deposition and distribution of cementum on the root surfaces so as to maintain the optimal width of the periodontal ligament space. So the process is counterbalanced by hypercementosis through which there is distribution of cementum along the root surfaces so as to maintain the optimum width of the periodontal ligament space. Second point is your inflammation of a tooth. Now, inflammation of the tooth can usually take place involving the pulp chamber or the pulp canal or the pulp tissues, especially pertaining to the apical third of the tooth root. Inflammatory changes of the pulp chamber or pulp canal, especially pertaining to the pulp tissue in the apical third of the tooth root, might lead to hypercementosis or deposition of excessive cementum, especially in the apical third of the tooth root. Now, repair. Sometimes it is observed that owing to occlusal stress or trauma, it will lead to minute areas of microscopical bony resorptions and microscopical root resorptions in the permanent tooth. As a result of this resorption, it has to be repaired. That is the body's normal defense system. So how will it be repaired? It will post this microscopic resorption, so into occlusal stress or trauma. The repair will be by means of deposition of cementum or bone or a combination of osteocementum like complexes. So the repair will be by means of deposition of cementum or bone or a combination of osteocementum like complexes. Now, fifth point is your association with systemic debilitations. Systemic debilitations like Paget's disease might lead to generalized distribution of cellular or secondary cementum throughout the root surfaces. Systemic disturbances like Paget's disease might lead to distribution of cellular or secondary cementum throughout the entire root surfaces. Along with this, there is disappearance of lamina dura. Along with this, there is disappearance or loss of lamina dura. This is the characteristic feature. Now coming to the fifth point, which is idiopathic. Idiopathic causes of hypercementosis might include a condition known as cemento-osseous dysplasia. I repeat, the condition is cemento-osseous dysplasia. The spectrum of cemento-osseous dysplasia or excessive hypercementosis can be of 3 types. It can be either focal cemento-osseous dysplasia, wherein it usually affects incisors, particularly the mandibular incisors. The mandibular incisors are particularly liable to be affected by focal cementosseous dysplasia, and these teeth are completely asymptomatic and painless in nature. It usually affects African women of middle-aged ethnicities. Now, when another type of cementosseous dysplasia is your periapical cementosseous dysplasia. In periapical cementosseous dysplasia, a few teeth might be affected. In focal, single tooth was being affected, which was usually the mandibular incisors. In periapical, a few teeth will be affected. And another type of cementosseous dysplasia is your florid type of cementosseous dysplasia, in which multiple teeth across and involving multiple quadrants, including but not limited to maxillary and mandibular arch, will be affected. So there are three types of cementosseous dysplasia which can lead to this type of idiopathic hypercementosis, and these include focal, periapical and florid cementosseous dysplasia. Another type of cementosseous dysplasia or hypercementosis include a regional sporadic formation of cementum in this region, which can lead to hypercementosis also. Now, what are the clinical features? Usually, you will find no clinical features. There is no pain, no sensitivity, no tenderness on horizontal or vertical percussion. There is no pain, no sensitivity, no tenderness on either horizontal or vertical percussion. The point to note is the roots of the teeth affected in hypercementosis will be larger, broader, blunter and wider than that of the normal tooth. So the roots of the teeth affected in hypercementosis will be larger, broader, blunter and are wider than that of the normal tooth, and the apices are bulbous and rounded in appearance. And the apices are bulbous and rounded in appearance. What are the radiological pictures of this type of hypercementosis? Radiologically, the clinical features will be corroborated, meaning the roots will be larger, broader, blunter and will have a greater width than that of the normal tooth counterparts. Along with that, the apices will be rounded and broader in appearance. Another point to note that radiologically, the root dentin will tend to possess a similar level of radiodensity as with that of the surrounding primary and secondary cementum of the root surfaces. So the root dentin will seem to possess a similar level of radiodensity in comparison to that of the surrounding primary and secondary cementum which is covering the root. So these are the radiological aspects of hypercementosis. Now coming to the histological aspects of hypercementosis or cemental hyperplasia. Hypercementosis is also known as your cemental hyperplasia. Now, in histological aspects, we observe that there is distribution of cellular or secondary cementum across and encompassing the entire root surface over a layer of thin primary or acellular cementum, which is usually focused to the apical third of the tooth root. I repeat again, there is distribution and deposition of secondary or cellular cementum over and above the entire root surface above the level of a thin layer of primary or acellular cementum, and this is predominantly focused to the apical third of the root surface. So the secondary cementum gets deposited over a layer of thin primary or acellular cementum which is focused to the root surface. This type of cementum is known as osteocementum. This type of cementum is known as osteocementum. owing to its qualities that it also resembles the bone and has cellular components. It is called osteocementum because it resembles bone and contains cellular components. As it contains cellular components and resembles the bone, it is known as osteocementum. This osteocementum in the apical third of the tooth root seems to be distributed sorry. The osteocementum in the apical third of the tooth root seems to be distributed in a concentric lamellated fashion. The osteocementum in the apical third of the tooth root is distributed in a concentric lamellated fashion and resting lines are evident. So these are the histological pictures of hypercementosis of tooth. Now we will come to the treatment of hypercementosis. Usually hypercementosis requires no treatment. If you try to excessively apply force and do an extraction of a tooth which is affected by hypercementosis, it will do more harm than good. So no treatment is the best treatment here because it will not only derange the periodontal ligament space, the supporting attachment apparatus of the tooth, but it might as well also affect the surrounding tooth in this region, and the alveolar bone might also get affected in this manner. Now we will shift our focus to cementicles. What are cementicles? Cementicles are nodular diffuse calcific masses which lie within the periodontal ligament space which are not true cementum. These are nodular calcific masses which lie within the periodontal ligament space which are not comprised of true cementum, and these are an example of dystrophic calcification. Now, what is the pathogenesis or mechanism of formation behind this type of cementicles? Now, they can be formed due to a myriad of reasons. One school of thought says that it is owing to calcification of a group of epithelial cell rest which are present within the periodontal ligament space. So calcification of epithelial cell rest present within the periodontal ligament space, such as the Hartwig's epithelial root sheath, which is an epithelial remnant of dental lamina within the periodontal ligament space, might lead to its calcification and subsequent formation of the cementicles. The cementicles formed in this way have a concentric lamellated nature. And they grow outwards by acquiring more calcium salts. So they have a concentric laminated nature, and they grow outside or outwards by acquiring calcium salts. Another school of thought says that these cementicles can arise by calcification of a portion of Sharpie's fibers. So calcification of a portion of Sharpie's fibers might also lead to formation of the cementicles. Now, cementicles can be of two types, mainly free cementicle and attached cementicles. Now, what are free cementicles? These are the type of cementicles which lie totally freely within the periodontal ligament space. So the cementicles which lie totally freely within the periodontal ligament space are known as free cementicles. And what are attached cementicles? The type of cementicles which are partially fused to the osteodentin complex, to the walls of the root dentin, or even to the alveolar bone are known as attached cementicle. So attached cementicle is that type of cementicle which is partially fused or attached to the root dentin, the osteodentin complex, the osteocementum, or simply to the alveolar bone. These are known as attached cementicle. Now another mechanism for formation of these cementicles are idiopathic and inflammatory. An inflammatory change might lead to certain calcific changes which might lead to the formation of cementicles, but it is not very clearly elucidated. Another point which is responsible for the formation of cementicles is the presence of thrombotic microcapillaries within the periodontal ligament space. If there is a thrombotic microcapillary within the periodontal ligament space, if it has achieved occlusion or if it has ruptured, then what happens? There is a central nidus of necrotic cellular or tissue debris. There is a central nidus or cellular or tissue debris. Surrounding the central nidus of necrotic cellular or tissue debris, their body will form concentric laminated calcification in the form of cementicles. Apart from that, tears or tearing of cemental fibers in close proximity to the periodontal ligament and Sharpie's fibers can also lead to the formation of cementicles. So these are the pathogenesis or mechanisms through which cementicles can be formed. Now, radiologically, these are not very much discernible until and unless there are a large or excessive number of cementicles throughout the periodontal ligament space, which are like tiny radiopaque flakes which can cause disturbances in the periodontal ligament attachment apparatus during mastication or chewing of food and later on lead to any pathosis. So this much for this day. We'll continue in the next day. Thank you for your patience.